with the important subject, and that is neonatal seizure. Of course, neonatal seizure is not uncommon in the neonatal period. Neonatal seizure may present in different clinical symptoms and signs. So, subtle seizure, which manifests as rhythmic eye deviation or blanking lip, smacking, tongue thrusting, fluctuation of the vital sign, or apnea. And these are the most common form. So it's this subtle, maybe not so obvious, the non-expert one. These subtle signs may be followed by generalized, tonic, multifocal, clonic, focal clonic, and myoclonic seizure. So, full-blown picture of characteristic for each seizure, of course, may be seen by a newborn. In fact, a newborn may accept certain movement that may be mistaken as a neonatal seizure. So, we have a benign juturness or tremulousness in the infant of diabetes mother, in infant with narcotic withdrawal. In contrast to the seizure, juturness and tremor considered most common than neonatal seizure, and these findings due to sensory dependent elicited by stimuli and interrupted by holding the extremity. Juturness, of course, due to normal phenomena or exaggerated by hypocalcemia and even hypocalcemia. So hypoglycemia and hypocalcemia play an important role. Juturness in general considered to be normal within the first 2 weeks, while juturness after that you should seek for the cause. So juturness can be stimulated by certain stimuli and stopped by holding the extremities. Seizure activity becomes marked as a coarse, fast, and so clonic activity, while juturness is characterized by fine, rapid movement. Fine, rapid movement. Seizure may be associated with abnormal eye movement. So juturness stopped by stopping the extremities and considered fine, rapid, rather than slow clonic activity. Keep this in mind. Of course, every serious condition should result from different causes. Asphyxia, important cause for neonatal seizure. Brain anomalies, important tractable cause of neonatal seizure. Intracranial hemorrhage, systemic metabolic disorders, hypoglycemia, hyponatremia, hypernatremia, hypocalcemia, hyperammonemia. Of course, inborn error of amino acid and organic acid metabolism may be considered as a cause. Meningitis and encephalitis, important cause that should be diagnosed and treated earlier. Pyridoxine deficiency, important cause of neonatal seizure. So generally, if we find a neonatal seizure and we exclude meningitis and encephalitis and electrolyte disturbance, then we should think about pyridoxine deficiency, especially when the pregnant woman ingests a large amount during gestation. So here, give us a picture of withdrawal effect. Diagnosis of the neonatal seizure. Following evaluation should be made in effort to pinpoint the cause of seizure. Important neonatal examination to be detailed and inserted. First, EEG, important, ultrasound and CT of the brain, screening for metabolic disorder, glucose, calcium, sodium, or amino acid or organic acid for inborn error of metabolism. Don't hesitate to do lumbar puncture when indicated for a neonatal seizure, because if you leave a meningitis without diagnosing accurate treatment, you get a crippled human being. So lumbar puncture, not harmful test, and should be done most of the newborn that develop fit. Of course, the treatment of the neonatal seizure depends on the cause, but first, you should stop the fit by usage of benzodiazepine in form of diazepam in a dose of 0.4 milligram per kg. And this, of course, can be repeated every half hour, total 3 doses. This drug may be followed by phenobarbital in a dose of 10, maybe increased to 20 milligram per kg. Phenytoin may help, of course, beside the correction of the metabolic disorders. Important subjects, neonatal hypoglycemia. Of course, 45 milligram per deciliter, consider a low limit for most of the newborn. After that, random blood sugar should be increased with increasing the age of the newborn. Hypoglycemia, considered very common in infants of diabetic mother, as well as infants who are born after various perinatal complications like premature uterine growth retardation and asphyxia. What are the most common causes behind neonatal hypoglycemia? Maternal diabetes. The hypoglycemic infant of diabetes is the result of hyperinsulinemia, a state that persists after umbilical cord is cut and the maternal supply of glucose is interrupted. Neonatal hyperinsulinemia, of course, due to high level of glucose that pass from the maternal circulation to the fetus, and so the fetus starts to increase its secretion from insulin to antagonize the high level of glucose. After cutting of the cord, effect of insulin start to be continued for a few days. Prematurity, important cause of neonatal hypoglycemia. Preterm infant become hypoglycemic owing to diminished glycogen store and to immaturity of gluconeogenic enzyme. Growth retardation, important role in hypoglycemia. Perinatal asphyxia, force the fetus to cause anaerobic metabolism, which quickly deplete stored glycogen. As you know, the glycogen is storage form of glucose. Cold stress increase oxygen consumption as well as glucose consumption. Also may be increased free acid and result in hypoglycemia. Sepsis cause hypoglycemia, although in a less degree, hyperglycemia may be seen. Beckwith-Whitman syndrome is an important syndrome that causes severe hypoglycemia, visceromegaly, macroglosia, and infamously. Hyperinsulinemia, secondary to the pancreatic islet cell, hyperplasia is responsible for hypoglycemia. Residuoblastosis and pancreatic islet cell adenoma are also important causes for hyperinsulinemia. Metabolic disorder, so galactosemia and pan-hypopituitarism, important cause of hypoglycemia. So we have another causes, but these are the most common that should be kept in mind. Clinical features. Infants with hypoglycemia are not always symptomatic. However, the following symptoms may occur: hypotonia, jitteriness, apnea, tachypnea, cyanosis, hypothermia, poor feeding, and even seizure in severe hypoglycemia. So you should hypoglycemia if you take a detailed history to know the risk factor that may result in hypoglycemia. Treatment, important, because hypoglycemia, if left without treatment, result in severe brain damage. So primarily, we can use intravenous glucose. The glucose infusion may be required. For several days until the basal insulin secretion rate decrease. So glycogen store are replenished or gluconeogenesis improve. You should avoid bolus infusion of hypertonic glucose because they may result in a rebound hypoglycemia, and give us effect the same of infant of diabetic mother in utero. So you should start with continuous infusion. Intravenous glucose should be administered as a constant infusion, begin at a rate of 6 to 8 milligrams per kg per minute. Of course, this may be increased according to the need to a rate of 20 milligrams per kg per minute. Of course, central venous access should be used for infusion given at a rate above 20 milligrams per kg per minute to avoid the thrombophlebitis. So when increase the concentration of infused glucose, you should change the site of the infusion. A small 0.5 to 1 gram per kg bolus may be used for extreme hypoglycemia or if severe symptom related to the hypoglycemia. This should always be followed by constant infusion. So here, if you need a bolus, should followed by infusion, should be followed by infusion. Hypoglycemia that is secondary to hyperinsulinemia and resistant to intravenous glucose should be treated with corticosteroid or diazoxide. Available drugs that may help to antagonize the effect of insulin and help to increase level of glucose. If drug treatments fail, partial pancreatectomy should be performed. These more aggressive forms of therapy rarely are necessary except for hypoglycemia that associated with Beckwith-Whitman syndrome, residuoblastoma, or islet cell adenoma. So these small tumors start to be secrete insulin in high levels. So you should interfere to stop or reduce the source of insulin by removing such tumors. Talk about special issue, infant of diabetic mother that result in severe hypoglycemia and other certain complications. Women with diabetes in pregnancy are at increased risk for adverse pregnancy outcome. Adequate glycemic control before and during pregnancy is crucial to improve the outcome. Of course, the effect of diabetes on the fetus depends in part on severity of diabetes state, age of onset of diabetes, duration of treatment with insulin, and presence of vascular disease. Poorly controlled maternal diabetes leads to maternal and fetal hyperglycemia that stimulate the fetal pancreas, resulting in hyperplasia of the islet of Langerhans. So fetal hyperinsulinemia results in increased fat and protein synthesis and fetal macrosomia. So hyperinsulin secretion result in increase the fetus weight, except brain and ossification center. Both these still immature in comparison to the weight of the newborn. We continue with infant of diabetic mother. Neonatal hypoglycemia develop in about 25 to 50% of infant of diabetes mother, and 15 to 55% of infant of the mother with gestational diabetes. Of course, gestational diabetes means the mother completely healthy without diabetes before pregnancy. and become diabetic just during pregnancy. And of course, diabetes will be cured after labor. So, the clinical sign of hypoglycemia and other complications to be less with gestational diabetes, Therefore, these infants should initiate feeding within 1 hour after birth, and screening glucose tests should be performed within the first hour of birth. In asymptomatic infant, treatment indicated if plasma glucose less than 30 milligram per deciliter. In symptomatic infant, the treatment indicates if plasma glucose less than 40%. Treatment of hypoglycemia, as mentioned in treatment of neonatal hypoglycemia. The same treatment that we mentioned just before. So don't leave the infant of diabetic mother to suffer more with hypoglycemia that resulting in severe brain damage. Important subject because it is a preventable condition, so always keep in mind. What are the complications of infant of diabetic mother? Birth asphyxia, birth trauma due to increased body weight, hypoglycemia, hypocalcemia, hypomagnesemia, polycythemia, and indirect jaundice. Congenital anomalies is increased threefold, like congenital heart disease, neurological disorder like neural tube defect, renal disorder like double ureter renal vein thrombosis, and the most complication regarding respiratory distress syndrome. Preterm labor is a common and the result of fetal distress or due to planned early delivery. So important to ask the mother to control their blood glucose during pregnancy to minimize the effect on the newborn. It's clear to make a rapid look and comparison between these two infants, the larger one with maternal diabetes, while the other one with normal delivery, Prognosis, neonatal mortality rate, 5 times more than usual. The subsequent incidence of diabetes mellitus in infants of diabetes mother is higher than that in general population. So the key to optimal outcome is consists with glycemia in the mother. Tell the mother to be in contact with their doctors to minimize the effect of glucose and minimize the later on neonatal problem. Another important subject, beside glucose, the calcium. Hypocalcemia is a common in sick and premature. Total serum calcium level less than 6 milligram per deciliter, and ionized calcium levels of less than 3 to 3.5 milligram per deciliter are considered hypocalcemia. As you know, total level of sodium composed of ionized and non-ionized calcium. The important part of fractionation is the ionized calcium. So if we have a less ionized calcium, the sensitivity of hypocalcemia, of course, so obvious. As you know, half of the total calcium we have early and late hypocalcemia. Early onset neonatal hypocalcemia occurs in the first 3 days of life and is often asymptomatic and can result from transient hypoparathyroidism or congenital absence of parathyroid gland, and even seen by others in Di-George syndrome. Hypomagnesemia, most of cases followed hypocalcemia, a level of 1.5 considered hypomagnesemia that may be seen with hypocalcemia that may need to treat both conditions. So, in treatment, if you have hypocalcemia and you infuse intravenous calcium and the condition not improve, you should think about hypomagnesemia that should be treated at the same time. Late onset neonatal hypocalcemia, of course, result from high phosphate containing milk, inability to excrete the usual phosphorus in the commercial infant formula, vitamin D deficiency, and of course due to malabsorption for any cause. So these are the most common causes that possibly causing late onset neonatal hypocalcemia. Clinical signs include apnea, muscle twitching, seizure, laryngospasm, chuvastic sign, and trachea sign can be seen more with late onset hypocalcemia. Neonatal hypocalcemia may be prevented by administration of intravenous or oral supplement at a rate of 25 to 75 milligram per deciliter per day. Early asymptomatic hypoglycemia of preterm infant and infant of diabetic mother often resolve spontaneously. Symptomatic hypocalcemia should be treated with 2 to 4 ml per kg of 10% calcium gluconate, of course given intravenously and of course slowly over 10 to 15 minutes, followed by continuous infusion of 75 milligram per kg per day of elemental calcium. Of course, during calcium infusion, you should put your stethoscope on the heart to assess the heart rate, because calcium may result in bradycardia. At that time, you should stop the infusion and may return the infusion back after improvement of the heart rate. Hypomaglycemia, of course, treated by 50% magnesium sulfate by a dose of 0.1 ml per kg given by IM and can be repeated according to the situation. Treatment of hypocalcemia include immediate management as in early hypocalcemia, plus the initiation of feeding with low phosphate formula. Generally speaking, effect of hypocalcemia on the neonate less in comparison with hypoglycemia. Hypoglycemia can result in severe brain damage because the brain completely depends on its energy on glucose, while calcium for a short period not causing a severe damage like in that of hypoglycemia. So hypoglycemia should be treated immediately. Here we shift our attention to another very, very important subject in the neonate, and that is sepsis and meningitis. Sepsis and meningitis, of course, can be affect newborn for certain and different causes according to the nature of the newborn. Infections continue to be a major cause of neonatal mortality and morbidity despite advance in therapy. Although perinatal acquired bacterial infections are the most common, infections that are acquired in utero remain an important source of long-term disability. So, infection of the newborn may start in utero. So, this important possibility should raise the pediatrician about this possibility, despite acquired infection considered to be most common. What are the risks for such problem? In fact, any healthy newborn considered to be a risk for neonatal infection or sepsis, because newborn itself considered a risk factor for infection. The newborn is particularly susceptible for infection owing to the immaturity of the immune system, and that include defect in the neutrophil chemotaxis, defect in the neutrophil phagocytosis, and defect in mechanisms that act against bacterial activity, beside the defect in the humoral component of the immune system of the newborn. Preterm infant before 32 weeks of gestation have not received a full complement of maternal antibodies which cross the placenta. So 6-fold higher rate of sepsis in the preterm infant in comparison with the term infant. This differs, of course, due to the immature immunological system of a preterm infant, beside prolonged hospitalization and nosocomial infections. So, premature, in spite of their immature of immunological system, may expose to other factors that increase their incidence in neonatal infections. Defense mechanism against viral also not so completed in the newborn. Male infants seems to be more susceptible to the infections in comparison to the female. Bacterial sepsis and meningitis often are linked closely in the neonates because the causative agent of meningitis most frequently are the same as for neonatal sepsis. So, neonatal sepsis more in the preterm. So, from the previous lectures, you can collect the conditions that affect preterm in comparison to the conditions that affect the term and post-term, and you should aware about the conditions that affect both preterm and term infant. Here, preterm suffer more. We can classify the neonatal sepsis to 3 groups. First, early neonatal sepsis. Start from the birth to the 7 days, often begin in utero, and usually caused by bacteria in the maternal genitourinary tract. And the organisms include group B, Streptococci, E. coli, Listeria monocytogenes, and Klebsiella. Most affected infants are premature. So infection starts in utero and then affect the newborn up to 1 week. Prolonged membrane rupture more than 24 hours and vaginal colonization are a major risk factors. These infants frequently manifest as respiratory failure, shock, meningitis, with early symptoms like grunting, poor feeding, pallor, apnea, lethargy, hypothermia. Of course, these last symptoms going to be non-specific. How you evaluate early neonatal sepsis? Of course, should be suspect any neonate with previous signs, symptoms, and risk factor. So you should send for blood and CSF cultures with biochemistry. In fact, when you suspect neonatal sepsis, you should send a culture for all normal body compartments. Culture of blood, culture of CSF, culture of urine, and culture for gastric aspirate. Biochemistry is so important, like calcium, glucose, electrolytes, and even renal function test. Bacterial antigen in the blood and cells and urine should be assessed. PCR may be used to identify the viral infection. C-reactive protein may be helped in bacterial infection. Chest X-ray should be used to determine pneumonia. Blood gas analysis should be monitored carefully. So your workup in early neonatal sepsis should include these issues. Treatment of early neonatal sepsis. Of course, the important line by use of antibiotics, then use ventilation assisted and cardiovascular support. Of course, beside fluid and monitor other biochemical changes. So a combination of ampicillin and aminoglycoside for 10 to 14 days is effective treatment against most organisms in the early sepsis. So the combination of ampicillin and cefotaxime is alternative method. So we have two regimes as a combination of antibiotic, either ampicillin plus aminoglycoside or ampicillin plus cefotaxime. Here, you note ampicillin present in both regime. Why? Because Listeria monocytosis should be treated effectively with ampicillin. So ampicillin should be present in two regimes. If meningitis is present, the treatment should be extended to 21 days or 14 days after negative result from CSF culture. Respiratory support and surfactant usage may reverse respiratory failure, especially in the premature. Fluid support and blood sugar is important. Important always to send for random blood sugar. In fact, if you have 1 drop of blood, you should send for blood sugar and then think about other. Late onset neonatal sepsis from 8 to the 28 days usually occur in a healthy full-term infant who are discharged in a good health from the normal newborn nursery. So this affects mature baby that may present with lethargy, poor feeding, hypotonia, seizure, bulging fontanelle, fever, and direct jaundice, not indirect, direct jaundice. Focal infection may present such as meningitis, osteomyelitis, arthritis, and urinary tract infection due to different microorganisms that mentioned earlier or so clear in front of you. Staph aureus, potent cause for neonatal sepsis. The evaluation and treatment of late neonatal sepsis similar to that of early onset, and here we can use a vancomycin should be added to the regime, especially if we have a recent microorganism like Staph aureus. Of course, you start with empiric treatment. As we say, either use of ampicillin plus aminoglycoside or ampicillin plus third-generation cephalosporin. Then you can change the antibiotic regime according to the culture, according to the culture. Number 3 of neonatal infection, nosocomial infections. Nosocomial infection. Nosocomial from 10 days to discharge. Occur predominantly in a premature infant in the neonatal intensive care unit. Many of these infants colonize with multi-drug resistant bacteria. So early onsets, neonatal sepsis and nosocomial acquired sepsis occur predominantly in premature, while late onset occur more in term infant. The risk of such serious bacterial infection by frequent antibiotic use and by the presence of central venous catheters, endotracheal tube, umbilical catheter, and device of infant monitor. So, most of the infection acquired from environment around the preterm during its admission in intensive care unit. Most bacteria that's responsible about this condition is a colase negative Staph aureus, gram-negative, bacilli, and even viral adeno, rotavirus, and respiratory syncytial virus. So this may be caused by bacteria, virus, and even fungus. Clinical presentation for nosocomial sepsis may be subtle and include apnea, bradycardia, temperature instability, abdominal distension, and poor feeding. This neonate may present later with shock, DIC, respiratory distress, and local skin infections. Treatment of nosocomial depend on the flora of the particular hospital and antibiotic sensitivities. A combination of vancomycin or oxacillin or nafcillin, some use ampicillin with vancomycin, or with a minor glycoside like gentamicin or dobramycin. A minor glycoside serum level should be followed and monitored all the time to avoid nephrotoxicity or ototoxicity, especially in premature. Persistent sign of infection despite antibacterial treatment suggests candidal or viral infections. Once data culture available, therapy should be tailored to the specific microorganism. The duration of therapy usually about 10 days, except for invasive infections like meningitis or osteomyelitis, which require longer course of antibiotic therapy. Any complication that happen should be treated accordingly, and don't forget a fluid that calculated according to the need, depending on the weight and condition that happened during treatment. So important subject that mostly depend on usage of antibiotics, fluid support, and support system that affected more by infections. Important for you when admit premature neonate to the intensive care unit. Important for you to minimize the manipulation of the newborn and to minimize the venous aspirate of blood and keep the media sterile all the time. Important last subject to be mentioned, that is congenital infection. From its name, it's an infection that acquired transplacentally during gestation. Congenital infections include well-known group of fungal, bacterial, and viral pathogens, including toxoplasmosis, rubella, cytomegalovirus, herpes virus, varicella, zoster virus, congenital syphilis, important for newborn that may present with certain skin manifestation or teeth abnormalities, parvovirus, HIV, hepatitis B, and chlamydia. These are the possible causes that cause infection in utero. Many of the clinical representations of congenital infection are similar, including intrauterine growth retardation, anemia, thrombocytopenia, direct jaundice, hepatosplenomegaly, chorioretinitis and cataract, and congenital malformation. Evaluation of patients should include attempt to isolate the organism by culture, identify the antigen of the pathogen, use the PCR and specific fetal antibodies. Treatment is not always and not effective with congenital infections. So the best thing to make a preventive measure to avoid such conditions, and especially to treat the mother before getting pregnant if she is well known to be carrying one of these important microorganisms that we mentioned. So important, so difficult, and the result not so encourageable. So better to be avoided, Up to this point, we finished the issues that mostly to be seen in the neonate after birth. Now, I'm ready to receive your questions here or even on classroom.